teeth, tongue, oral mucosa, or pharynx. Why do you think that you have saliva that's produced in your mouth, besides to aid in mastication? What's mastication? Chewing. Chewing is mastication. Okay, that's a fancy term for actually chewing food. But if we're talking about the respiratory properties, the reason why you have secretions in your mouth and also in your nose is two things, two basic principles. Anybody know what they are?
Lubricate.
No, not lubricate.
Is it a natural salt?
No. Filter, I like it, but primary is to warm the air up, okay? And the next thing is to humidify it. What does humidify mean?
Put moisture in the air.
Put moisture in the air, all right? Putting moisture in the air and providing warmth makes it easier on your airway passageways to reduce inflammation, okay? So once we get past the oropharynx, just get here when you can. We done had 3 quizzes. So once we get past the oropharynx, where does it go? It goes to the pharynx and the posterior pharynx, and that's the back portion of your airway, where your tonsils, that little dangly thing, what's that little dangly thing in the back of your throat called? Uvula. Okay, don't get it mixed up with the vulva.
I did get mixed up.
Yeah, one's lower that you don't have, and one's upper that you do have. Don't get it mixed up. Because if you get mixed up in your lecturing, like me, you'd embarrass yourself.
It's on the.
Okay? All right. So once we get past there, we have some specific anatomic structures that you should be very familiar with. Tell me about the epiglottis. What does the epiglottis do?
It prevents from food getting to the airway.
Is it something that you control, or is that part of the autonomic nervous system?
Autonomic
nervous system. Okay? So when we talk about procedures, when we talk about oral tracheal intubation, there's 2 different types of blades. We have the McIntosh blade, which are curved, and then we have the Miller blade, which are straight. Tell me about specifically where those go.
The Miller goes on top of the epiglottis?
Well, it actually goes not on top of it, it goes under it, because you're going to pick it up, right? So if you try to put it on top of the epiglottis, it's not going to work out too well, all right? McIntosh blades, where do they go?
Kind of pulls the tongue forward.
Yeah, but there's a very specific anatomical landmark it goes into. It starts with a V.
The vallecula.
Vallecula, right? So, the theory behind the reason why they came up with a curved blade is 2 reasons. Is they felt like it was more of an anatomically correct blade. And what's the difference between what's the big difference between, besides the shape of a Miller and a McIntosh, what's the other big difference between the 2? Do you know?
Wider.
Wider. Why are McIntosh wider?
I have no idea.
Anybody? Take a guess. Just think about it. There you go. Is that what you said, Mason?
It is Mason, I'm good.
You sound like a ventriloquist. I'm like, you're able to talk through Neil? That's pretty impressive. Good Lord. All right. So as we get past that, all right, so we're looking at a patient, and the trachea is anterior to the esophagus, right? Is that correct?
Yes.
Yes. Okay. Tell me about the anatomical structures of the esophagus. What's the differences between the esophagus and the trachea? What's the difference? Not bigger.
The esophagus is
It's more elastic. Okay. Think of a rubber band. Okay. That's what the esophagus feels like. Okay. It's very stretchy. It's very what we call malleable, which means the reason why is because it has to. Food goes down it, so it needs to be able to stretch. Believe it or not, to give you a better understanding, to operate on the esophagus, say you have an esophageal tear, a Mallory-Weiss tear, and that's kind of a national registry question that we'll get into in the 3rd semester, is that it's very hard to operate on because it's such a muscular organ, is that it's very challenging to operate on. So it's one of those very delicate structures. It's a very tough but delicate structure to work on. So, well, if the esophagus is kind of like smooth muscle and it's very elastic, tell me about the trachea then.
surrounded with cartilage.
Have you ever seen ventilator tubing? It's kind of hard, okay? Do you know why it's like that instead of soft?
Because
In case a patient lays on it, specifically designed, if a patient lays on it, it won't collapse. Okay, so it's very similar to what's going on with the trachea. All right, so tell me when I say what's the glottic opening, what does that mean to you? What's the glottic opening mean to you?
the opening that the epiglottis is covering.
Okay, all right, so where you see the vocal cords at, right? Does this thing come apart? Oh! You're gonna break it.
You gotta pay for that.
I'm gonna break it. Uh-oh.
My shit about to die, bro.
I got it. But if you see the glottic opening where the vocal cord's at, that's the narrowest part, right? And yes, they are white. If you haven't seen them yet, they are white. All right. What did I tell you? All right, let's do it the right anatomical way so you can see it perfectly, because this is the patient laying supine. Okay. So when we look, what's this thing that I'm touching right now? Say it with confidence. It's an epiglottis, damn it. Okay. So what's this right here? Where's my thumb at, my finger at right now? Vallecula. Okay. What did I tell you these little bumps are? No? If you don't remember, I walked around and showed this to you. It starts with an A. Nobody remembers? Arytenoid cartilage.
Oh.
All right.
It was
Okay.
something cartilage.
Why did I want you to know where the arytenoid cartilage is? What's
Landmarks.
the importance of that?
Landmarks.
It's a landmark. Okay. One of the biggest problems you guys are going to have intubating, or as you're learning to intubate, is to learn the airway. You have to know the anatomy. And if you don't know the anatomy, when you're looking at it, how the hell are you going to know what you're looking at? Okay? So I like this view. But that glottic opening is where the vocal cords open and close. So for example, when we push a drug like succinylcholine, what do you think it does to the vocal cords?
Relaxes.
It relaxes them. Okay? Relax them. All right, that's good stuff. All right? So as the right, if we look at the natural bifurcation of the right and left lung, does anybody know why you have a 98% chance of right main stemming a patient as opposed to left main stemming a patient when you intubate somebody? Anybody know why?
This is more
The right man's been larger.
Oh, it's not larger.
It's kind of higher.
Yeah, it has a kind of a natural pathway that it's going to go to the right. Where it bifurcates and switches into the right and left, what's that thing called? You almost had it. Quit! Carina. Carina. All right? Okay? When we look at the endotracheal tube,